platelets. Without these two, you cannot make clot. So if a patient has a problem with clotting factor or platelets, clotting will not happen. You have to have both perfect, okay? So they need both. That's the idea. Now, that's why they say when you have a thrombocytopenia, for example, when you have a low platelets, people started bleeding. The same thing when people have a liver failure, there is no clotting factor, they started bleeding. So they both requires to create a clotting. Now, the body knows how to activate the clotting pathway and when to activate, okay? Now, there is something called general pathway, okay? General pathway. These are in your book, you don't have to write now. The general pathway will bring the final product of clot, okay? Final product of clotting. The general pathway brings the final product of clotting. That general pathway can be stimulated two ways: extrinsic pathway and intrinsic pathway. So extrinsic or intrinsic, one of those two can stimulate the general pathway. If you stimulate the general pathway, you will get the final clotting product. Is that clear, folks? Okay. Now, if I take this picture and put it a little detail, that's what this one. Okay. Now, here, we call that general clotting pathway. Okay, that's your general clotting pathway, folks. Now, I'm going to start with the general clotting pathway first. You could see 10 factor 10 becomes 10A. Anytime you add letter A next to it, that means it's activated. Okay, that means it's activated. 10 becomes 10A. So let's start it. Take a paper and start it writing, folks. Okay, so we have 10 becomes 10A. So that's your first step. 10 becomes 10A. So the 10A joins with 5A. So if you ask, where did you get 5A? 5 becomes 5A, right? So 10A and 5A activate 2 to become 2A. So I could write that. So 10A joins with 5, which become 5A, activate 2 to become 2A. Okay, 2 to become 2A. Now, if you see here, look at the word for factor 2. Factor 2 is called prothrombin. Factor 2 is called prothrombin. Pro means precursor. Thrombin means clot. So once you activate, it becomes thrombin. Does that make sense, folks? So 2A is the most active form. So that's a thrombin, okay? Now, sometimes there's a pharmacology. We have a thrombin inhibitor. If I give a medicine to inhibit thrombin, they ask you which factor they work. People say 2, it's wrong. Thrombin inhibitors mean they work on 2A. Is that clear, folks? If it is working on factor 2, that should be a prothrombin inhibitor, not thrombin inhibitor. Is everybody clear, folks? Okay. So once you get factor 2, becomes 2A. Now 2A activates 1 to become 1A. Now I'm going to write 2A activates 1 to become 1A. That's all, the 3 steps, folks, if you see. Look at the word. 1 is fibrinogen. We know ogens are inactive, and once it became active, we call it fibrin. We call it fibrin, okay? So that's the most active form here. Now, what's going to happen here? That is your general pathway, folks. All these 3 steps is considered your general pathway, okay? Now, factor 1A will join with 3 things. I'm just going to write here. They join with 3 things: calcium and platelets. So they need 3 ingredients: factor 1A, calcium, and platelets. All 3 things joined together, we form primary clot. We form primary clot. In the book, it's shown, but it's a little different. You could see factor 1A joins with calcium, but they are not showing the platelet words. In my opinion, they put too low, but it should be up here somewhere. Okay, so that's why I write it here. So you need 1A, calcium and platelet, you form the primary clot. Is everybody clear, folks? All right. Now, why do I call this a primary clot? Every time we make a clot, first, initially, the clot that we make, it's like a simple clot. It's not a strong one. So we form the primary clot, which is simple clot, after about 3 to 3.5 hours. Okay. After about 3 to 3.5 hours, there's a factor 13. 13 becomes 13A. Okay. It's shown in your book. You could see factor 13 becomes 13A. What that 13A does, it makes the clot even more stronger. They make it more stronger to a point that you cannot break it, or it's hard to break it. Is that clear, folks? So that's factor 13. Now you should know factor 13s don't come right away. It takes 3 to 4 hours from the primary clot. Okay, so that's how the factor 13 comes and they make a clot. Give me a moment, folks. All right. So talking about the clot part. So that's your general pathway. Is everybody clear, folks? Now let's recap one more time. Factor 10 becomes 10A. 10A joins with 5A and activate 2 to become 2A. Once you get 2A, 2A activates 1 to become 1A. 1A joins with calcium and platelets, form the primary clot. And then once it forms a primary clot, after about 3 to 4 hours, factor 13 becomes 13A, make the clot stronger. Now, how do I put this in the clinical? If you know people who get stroke, one of the reasons to get stroke is ischemia. Basically, you have a clot in the blood vessel, isn't it, folks? Now, in the neurology section, we will learn when people come with clotting, we have to give a medication to break that clotting within 3.5 hours from the onset of symptoms. Okay, you have to give a medication to break the clot within 3.5 hours. Why do we call it within 3.5 hours? Because it's easy to break the clot before factor 13 comes in. Is that clear, folks? Once factor 13 comes, it becomes a little harder to break it. Now, can we break it after factor 13? It's all up in the air. Sometimes we can, sometimes we cannot. That's why when people have a stroke, you could never predict the outcome. Is that clear, folks? Right? If a person have a stroke in the hospital, sometimes their family comes and asks, like, for example, people get stroke. Stroke gives you different symptoms. Some people cannot move certain part of the body. Some people cannot talk. Some people lose memory. Different aspect, right? It all depends on which blood vessel is blocked. Is that clear, folks? Now, even after having a stroke, right? Like, for example, let's say recently one patient had a stroke that they couldn't move one side of the body because that blood vessel affected. They ask, would my mom get the function back? We tell, we don't know. We're going to try everything possibly because why? We are giving the medication with the hope of breaking it. If it breaks, she will get the function. If she doesn't, she won't. Is that clear, folks? So that's all we can do. So, but that's why you see the importance of giving the medicine before, because when you have a primary clot, breaking it within the first 3 hours is much easier than having the factor 13 comes in. Is everybody clear, folks? All right, take a piece of paper and write this. See, it's the 3 steps. See if you can write without looking. It's basically factor 10 to 1. That's all, 3 steps. Is that clear, folks? And then you have 5 coming in the middle. All right. So that is your general pathway. See, when you see this picture, it looks like there's a lot of things are happening. It looks very complicated. It's not. They just put a summary of everything together in one picture. Once we do everything, pharmacology, all these things, it will make sense, folks. Okay. But that's the idea. Now you could see factor 13 is called fibrin stabilizing factor. That means it makes it even more stronger. Okay. Now, any question in general pathway? Okay, now what we're going to learn, who activates the general pathway? Remember in our drawing, we said it's either extrinsic pathway or intrinsic pathway. So now we're going to talk about that now. Now, if you see here, I will start with the easy one, extrinsic pathway. When we call it extrinsic pathway, don't think it's outside the body. It's just a tissue factor. We have a name, extrinsic pathway, folks. Okay. Now we have factor 7. Factor 7 will become 7A, so the factor 7A is active. That 7A can easily activate factor 10 to become 10A. So in my drawing, I could literally say we have factor 7 becomes 7A that activate this. Is that clear, folks? That is your extrinsic pathway. That's it. One factor. That's your extrinsic pathway. 7 becoming 7A. 7 becoming 7A. Okay. Now, are you clear so far? All right. Let's go to the intrinsic pathway. Now, when we call intrinsic pathway, it's about just a collagen and basement membrane. That's all. Now, look at the factors. They're a little more here. Now, we are starting from 12. 12 becomes 12A, and we are going reverse. 12A activate 11 to become 11A. After 11, you would think 10, but we already have 10 in the general pathway, isn't it, folks? So we skip 10 and we go to 9. 9 become 9A. 9A joins with 8A, which came from 8, activate the 10. So it's 12, 11, 9, 8, except 10. Is everybody clear, folks? It's 4 factor, okay? Now let's go ahead and add that here, right? So we could tell, I'm going to start here. So I'm going opposite way, okay, folks? 12 becomes 12A, and 12A activates 11 to become 11A. 11A activates, what do we have next after 11? 9, because we have no 10, right? So that's activate 9 to becomes 9A. Okay, now you could see 9A joins with 8A. So 9A joins with 8A. So I'm going to put here somewhere the 8. Okay, so I could see it here. 8 becomes 8A, and together they activate the general pathway. So we call this intrinsic pathway, folks. So it's either extrinsic or intrinsic will eventually activate the general pathway. Now, when you learn this pathway, you should always write first general pathway. When you get the general pathway, it becomes easy. Don't just start from the top and go down. Always add the general pathway, then add the extrinsic, then you go for intrinsic. Is everybody clear, folks? All right. Take a new paper and see if you can write the whole thing without looking. Add a general pathway and then do it, folks.
Was there a reason why you made the 8 a different color and the way you did it
No.
before?
I just made it a different color so you could see it in my drawing. So it stands out.
Okay. And then
But they all belongs to intrinsic pathway.
9 goes to 8 and then goes to
No,
10. No?
9 becomes 9A, 9A and 8A together activate the 10. Look at this here.
Okay.
Here, 9A and 8A together activate the 10 to become 10A.
Got you. Thank you.
All of the A ones are the non-active forms.
A is the active ones. That's why we put A. If it is non-active, what's the point of changing 10 to 10A? So 10 becomes 10A, so we call it active. Is everybody clear so far? So we have intrinsic, extrinsic, and general pathway. Now let's start talking about how do we know these pathways works properly. The first thing to learn, to measure this pathway, to say that this pathway is working properly, we need to know two things, PT and PTT, right? There's a two pathway. There's a different way you could remember. I remember how my pharmacology teacher taught me. PET, PIT, this is how I remember, folks, okay? PET, PIT, what does that mean? PT is for extrinsic pathway, PTT is for intrinsic pathway, okay? Now, there are so many different ways people remember. You remember however you remember, but PT is for extrinsic, PTT is for intrinsic. Is everybody clear, folks? Now, the second thing, we need to know the timing. What is the PTT and PT timing? Somebody tell me, what's a normal PT? Now you guys start looking for the chart. It should be your fingertip. What is it?
Then before 12, I think 12.
It can't be one number. It has to be a range. 12 to?
Maybe
Okay.
like 8.
12 to 15. Okay. 12 to 15 is your PT. 25 to 40 seconds is your PTT. You know how you remember? 2 letters has less time, more letters has more time. Is that clear, folks? Less letters has less time, more letters has more time. Now, what does this timing means? Okay. Now, if I tell you that, or if I want to check a patient's, if the extrinsic pathway works or not. Now, don't write. Now, listen to me, folks, because there's some information here. Now, let's say, when we say PT is normal, when I say I have a patient, their PT is within the range. So when we say PT, the PT is basically measuring like this. It measures the extrinsic plus general pathway, okay? Because there is no measurement just for general pathway, folks, okay? There is no measurement for general pathway. We cannot measure the general pathway. So anytime I say patient has a PT normal, it tells you your extrinsic and general works fine. Is everybody clear, folks? Now, when I tell patient has a normal PTT, it tells you basically like this. That means your intrinsic and general pathway is working fine. It's always general includes in that. We cannot just measure factor 7, or we cannot just measure those intrinsic pathway factors. Is everybody clear, folks? Now, if somebody asks me, how do we know the general pathway works or not? Well, if both of them are normal, then we should know general pathway is working fine. Is that clear, folks? Now, that's how we use PT and PTT. So let's say some problem. What if I tell patient has increased PT and normal PTT? How do you interpret that? If I tell increased PT and normal PTT, the minute I see normal PTT, I know intrinsic plus general pathway is perfect. Is everybody clear, folks? Then I know the problem is factor 7. Is everybody clear, folks? So what does that tell you? You will never make a conclusion with just one. You need both. PT and PTT. You could never do that. So anytime you order a blood work, you have to have PT and PTT. Okay. Now, on the other hand, normal PT increase PTT. So what does that mean? Normal PT mean extrinsic and general is fine. Then I know for sure these are your intrinsic factor out of those 4 factors. Is everybody clear, folks? What if I tell you the last scenario? Increase PT and increase PTT, where the problem is? The problem is your general pathway. Is that clear, folks? When both are increased, that's how you know general pathway is defective. If you want, go ahead and write so you know that to learn, folks. Okay, this is important. Now, when I say the timing, what does that mean, folks? Let's say, I want to make sure Mallory's blood is clotting properly. If I take her blood and put it in a small bottle and I leave it on the table for 40 seconds, why do I say 40? Because that's the maximum. If I keep it in the bottle for 40 seconds and I take the bottle and I flip upside down, the blood should be clotted within 40 seconds. Is everybody clear, folks? So when the blood clots within 40 seconds, it tells PT and PTT everything works properly because the blood, that's the key. Blood should be clotting if there is no movement. Okay. Now, when you go to the clinics and they take a sample of your blood for testing, they never keep it in one place. They put it on a machine that keeps rotating, isn't it, folks? That's because if they don't rotate, it will clot. Is everybody clear, folks? All right. So that's the idea here, folks. Okay. So when they clot within 40 seconds, then we know both pathway works, folks. Okay. That's the idea. All right. So that's the timing. So PT and PTT. Is everybody clear with this? All right. So PT and PTT is a very good indicator to show how clotting works, folks. Now, that concludes in here how we form the clotting, how intrinsic and extrinsic pathway activate the general pathway. How do we form? Now, of course, we said platelet is part of it. Now we're going to have to go see how platelets play a role in here. Is everybody clear, folks? Now, to understand that, we're going to go to the previous page. This page is super high yield. Okay, I mean, all 3 pages, 19, 20, 21, it's a high yield. That's the most difficult to even teach, folks. Okay, so if you understand, you pretty much get the most. Now, let's talk about this platelet part, folks. Okay, now I'm drawing a blood vessel. That's your tunica intima. Okay. So tunica intima has endothelial cell. Under the endothelial cell, I put this X. These are called subendothelial collagen. I have subendothelial collagen, folks. Okay. Subendothelial collagen. Now within the blood vessel, I have this. I'll put a P. P stands for platelets. Okay, I'm just writing a couple of platelets so we understand that. So we have a platelet inside the blood vessels. Okay. Now, for any reason, if you have an endothelial cell damage, so let's say we have a little endothelial cell damage. The minute you have endothelial cell damage, you are literally exposing the subendothelial collagen. Is everybody clear, folks? So the minute subendothelial collagen is exposed, your platelet will come and bind to it. In healthy people, we don't do that because our subendothelial collagen is not exposed. Is that clear, folks? So the minute you expose the subendothelial collagen, platelet will come and bind. That first step where platelet binds to subendothelial collagen is called platelet adhesions. That is called platelet adhesion. Okay, now that is called platelet adhesions. It's not that simple. We just learned the word. We need to know how exactly it happens. There's factors that play a role in that. But once platelet adhesion happens, then what this platelet will do, so let's say that platelet is moving closer. Okay, so I'm just drawing it here. So that platelet moves here. Now that platelet will attract all the other platelet to come and join with them. So we call that platelet to platelet interaction. Is that clear, folks? So the first step is platelet adhesion. So what's happening in platelet adhesions? Platelet binding to subendothelial collagen. Okay, that's platelet adhesions. Once that happens, then you have platelet to platelet. We call that platelet aggregation. So if I ask you during the clotting process, which one happened first? Platelet adhesions or aggregation? What is your answer? Adhesions happen first, then aggregation. In another word, you need to have adhesions in order to activate the aggregation. Is everybody clear, folks? That's the two steps here. Now we need to learn how exactly this happens. Any questions so far? No? Good. Okay. Now what we're going to do, I'm going to zoom in a little bit to talk about how exactly that platelet adhesions works, folks. Okay. Now, if you go in the book, look at this. When the injury happens to the endothelial cells, you expose your subendothelial collagen. Is that clear, folks? When you do the subendothelial exposure, you have the first step, what we call platelet adhesions. Is everybody clear, folks? Now, how does platelet adhesions work? Now, adhesion works is by platelet. This is your platelet. That platelet is joining with the subendothelial collagen. Okay. Now, I want you guys to think this way. I am the platelet, and I have the wall next to me. That's a blood vessel wall. Okay. Now, for me to attach to the wall, which is your subendothelial collagen, the platelet needs their own receptor, what we call GP1B. So my hand is GP1B, folks. So GP1B belongs to platelets. That's me, platelet. But I'm going to go attach to the blood vessel. Now, in order to attach to the blood vessel, between my receptor and the subendothelial, I need something to hold on to it. So this pen is going to be your von Willebrand factor. So the von Willebrand factor is attaching the platelet to the blood vessel wall. So they are the intermediate, right? If you see here, that's your GP1B. This is your subendothelial collagen, and von Willebrand is the one in the middle. Is that clear, folks? So if I ask you what are the two factors needed for platelet adhesions, you're going to tell GP1B and von Willebrand factor. Is that clear, folks? You need those two factors, okay? GP1B plus von Willebrand factor. These are the two things that you need. Go ahead and write that. Once you have, now you tell me if you have a deficiency of von Willebrand factor or GP1B, can you do adhesions? You cannot. Okay, good. So that's platelet adhesions. Is that clear, folks? So if I ask you how does platelet adhesions work, the GP1B belongs to platelets by von Willebrand factor, so von Willebrand can attach to the wall. So von Willebrand factor is like glue that sticks the platelet to the wall. Is that clear, folks? All right. Now, once you see the book here, right? Once you activate adhesion, see it says platelet by von Willebrand factor via GP1B at the end there. But the key is, the minute I'm attached to the blood vessel, there's a conformational change is going to happen within my platelets, where I'm going to invite all the platelets to come and join with me. That's called platelet aggregation, isn't it, folks? So that conformational change happens by ADP. You can see here, there's the ADP receptor, the ADP getting activated. What the ADP does, it will, so I'm attached to this wall. So this is my GP1B, that's my von Willebrand, I'm already attached to the wall. As soon as that I'm attached, that change will expose another receptor on the other side. We call that GP2B3. You see that? We call GP2B3. And then let's say you guys are other platelets. So I'm inviting you guys to come and bind me so we can go for platelet aggregation. Is that clear, folks? Now, when you guys you guys also will carry the same receptor GG2D3. So I have GP2D3, you guys also have GP2D3. Now we need a glue to stick, isn't it, folks? That glue is going to be your fibrin. Where did we get that fibrin from? From your clotting cascade. Is that clear, folks? The end product of clotting is fibrin, isn't it? What is factor 1A called? Fibrin, isn't it, folks? So we go through the entire clotting pathway just to get fibrin. You could ask me, why did they put fibrinogen? I don't know. It should be fibrin. Okay. So fibrinogen get activated by fibrin. So all that fibrin is doing in clotting pathway, creating a glue for platelet aggregation. Is everybody clear, folks? Okay. So that's how the clotting pathway works. So now you could see it here. We have both platelets exposing the same receptor, but we need a glue to stick to that, folks. Okay, that causes platelet aggregation. And now you can see here, once you activate the ADP receptor, then aggregation will happen. Is everybody clear, folks? Now, in my paper here, you should always know you need to have adhesions in order to cause aggregation, because adhesions activate the ADP. The ADP brings the aggregation. So if I tell you, I have a von Willebrand factor deficiency just for a purpose, what other problem would I have? I would have a problem for platelet adhesions, correct? Would I also have a problem with platelet aggregation? Yes, because without adhesions, I cannot do aggregation. Remember that, folks? Whenever you miss one of these two factors, you can't just say it's an adhesion problem. It's an adhesion and aggregation problem, because without the first step, nothing else will happen. Is everybody clear, folks?
Can you repeat? I didn't understand that. I'm sorry.
Which part?
Just when you have both problems.
Okay. So what I was telling is, you need to do platelet adhesions in order to do aggregation. If you have a problem with adhesions, you cannot do aggregation either. So that's what I'm telling. If a patient has a problem with one of these two factors, which is needed for adhesions, they cannot do aggregation either.
And then what did you say about ADP?
Because that adhesion causes the ADP to activate so you can do aggregation. So the adhesion is the one that causes ADP activation.
So basically, you have to have adhesion first, then you can have aggregation, right? It's not like a two different things.
No, you need to have adhesion first and then aggregation. How does adhesion causes aggregation? Once you have adhesion, you activate ADP. ADP causes aggregation. So when you don't have adhesions, you don't have ADP. Without ADP, there is no aggregation. Okay. So if a patient coming with a clotting issue, and if I want to prevent the clotting, I don't have to go through so much. All I have to do is block the adhesion. If I block the adhesion, nothing will happen after that. Is that clear, folks? All right. So that is how platelet joins with this and works, folks. Now, what is the first step of all the problem here? Endothelial cell injury exposing subendothelial collagen. Does that make sense, folks? Okay. Now, when we studied DVT, there's a virtual triad, right? The three things, write it down. What are those three things?
Can you repeat the question, please?
What are the triad for DVT? Virtual triad. Everyone must type, because otherwise you cannot click it. Otherwise you won't put it together why they form clot. Come on, guys, don't search it. Write it down from your brain. See? Yeah. What are the virtual triad? Not a difficult question. I have three answers. So the three factors: stasis, hypercoagulability, and endothelial injury. And I wrote that day, out of all those three, the most important I asked you to highlight endothelial injury, isn't it? Why? It should make sense, because if you have endothelial injury, you will start the clotting. Is that clear, folks? Why endothelial injury? Having endothelial injury will expose your subendothelial collagen. Is everybody clear, folks? So that's the idea. So for people to develop clot, you need endothelial cell injury, which means they have to expose the subendothelial collagen. Are we clear, folks? All right. That is your clotting cascade. Any question for me so far? You guys are crystal clear with this? All right.
Repeat your analogy of sticking.
Say it again.
Repeat the analogy of sticking one more time.
So you mean the platelet adhesions?
Yeah.
So platelet adhesion is where the platelet attached to the subendothelial collagen. You need two GP1B and 1 millibrand factor. Once you attach, then we have a change happens through ADP, which causes aggregation, which is a connection between two platelets. And we use 2B3A, and fibrinogen becomes fibrin as a glue, and we stick to it. Okay. All right. So that take care of this page and this page. Okay. Any questions so far, folks? Okay. You see, they're talking about medications here. We cannot talk now. We just want the basics. Now let's go here. There's a little things to talk about. Now, this is a human body mechanism. The body, how it works. If a body created a clot, so let's say I had a clot, pathological clot somewhere. I went on a long flight. I had endothelial cell injury. I made a clot. Your body tried to break down that clot, folks, okay? Your body will always try to break down that clot. How does it do? There's something called plasminogen. We have plasminogen in our body. It gets converted to plasmin because plasmin is active. Who converts that? Tissue plasminogen activator, what we call TPA. We have that too. So as soon as we create a clot, your body will do this and get the plasmin. What plasmin will do, they try to break the clot. When they try to break the clot, they will get those broken pieces, what called fibrin degradation product. The fancy word is D-dimers. So D-dimers are broken pieces of clotting. Is that clear, folks? So why do we use D-dimers as a rule-out test? When we check for D-dimers, if D-dimer is present, for example, if we say D-dimer is positive, there is a blood broken product. Whenever you see a blood broken product, it tells you you must have had a clot in order to break it down. Is that clear, folks? If you didn't have a clot, you shouldn't have D-dimers. So when I say D-dimer negative, that means you do not have any clots that's breaking down. Is everybody clear, folks? So D-dimer is a blood broken product, the clotting broken products. That's what D-dimer is. That's a fibrin degradation product. Now, sometime when a patient comes with a clot, they come to the hospital. We know they have a clot. We wanted to break the clot. We could actually supply this TPA from outside. We have a synthetic form of TPA that we could give a high dose. Those are this medication, folks, okay? Streptokinase and all these things, TPA, we could give them those, right? That's the first medication we give it to people when they have a clot or stroke, ischemic stroke, what we call. Not hemorrhagic, but ischemic stroke, okay? So we could give more from outside to activate TPA. Is that clear, folks? Okay, so that's how. Now, do they become successful in breaking down? No, most of the time they would not, because they cannot. That's why they come to the hospital with the symptoms. Is that clear, folks? So the bottom line, your body tried to break down. They might break down a little bit, but they cannot break down. If they are capable of breaking down completely, nobody should have a stroke. Does that make sense? All right. But at least it's a hint. They try to break down a little bit so we know something is not right. Is that clear, folks? All right. So that's in this page, folks, okay? Now, let's go to the next one. This is the most difficult to explain. It looks simple, this page, but it's a lot in here, folks, okay? Let's go here. let's talk about blood clotting factors. There are different factors. Now, focus, okay? Factor 2, 7, 9, 10 CS. All these factors are in the blood, but they are inactive. They are inactive, folks, okay? So those are inactive. I'm just gonna say these 4 factors are actually clotting factors, and the C and S are actually anti-clotting. It's written on the bottom, but I'm writing it on the top also. Anti-clotting. You know, you should be wondering why. Our body has both factors, clotting and anti-clotting, folks, okay? Now, in order to activate these clotting factors and anti-clotting factors, you need the enzyme called glutamyl carboxylase, which is a vitamin K dependent. Now, how do we do that? When we take vitamin K, how do we get vitamin K, by the way? You could get it from outside, but it's a very small amount. The majority of the vitamin K is produced by your normal flora in your intestine. Your body produces. When they produce in oxidized form, which means they are inactive. So the vitamin K becomes active with the most important enzyme, epoxide reductase. Okay, epoxide reductase. Epoxide reductase activate the vitamin K. Once vitamin K is activated, they will actually activate the clotting factors 2, 7, 9, 10 CNS. Now they are active. Is everybody clear, folks? That whole process is called gamma carboxylation because it's doing gamma carboxylation by activating the carboxylase. Is that clear, folks? So that's why vitamin K is called gamma carboxylation. That's a function of it, folks, okay? Now, any questions so far? Once they activate, then you have active clotting factors and 2 anti-clotting. Now, one thing I want you guys to remember, 2, 7, 9, 10 is a clotting factors. C and S is an anti-clotting. So think in this way. These clotting factors are bad group. There's a 2 police undercover. They are with those bad people. Okay, because look at that. C and S is anti-clotting, isn't it, folks? So they prevent clotting. They are hanging out with these bad people undercover, but they are anti-clotting. Is that clear, folks? That's why every day we don't create clot in our body, because as we activate 2, 7, 9, 10, the CNS will keep neutralizing it. Is that clear, folks? So they keep neutralizing. That's why you're not creating a clot as we speak now, right? So we have CNS that neutralizing the toxic effect of 2, 7, 9, 10. Is everybody clear, folks? That's
So vitamin K activate these clotting and anti-clotting factors.
Yeah.
Is that what you said?
Yeah.
Okay.
Okay. Now, that's the basic functions. Is everybody clear, folks? All right. Now let's get to the complication. Let's clear this up. Oh, we don't need this now. Okay. Okay. So let's say sometime when people comes, sometime for certain disease, we're not going to worry about what disease, we give patient warfarin. When we give warfarin, what does warfarin do? It inhibits epoxide reductase. If you inhibit epoxide reductase, there is no vitamin K. Okay, there is no vitamin K. Now, before we move forward, I want you guys to type, what is the side effect you know of warfarin, acute side effect of warfarin that you heard before? It's okay if you are wrong, but type it up. I want to see what you guys know. It will make it easier for me. The acute side effect of warfarin. Acute side effect of warfarin. I'm not asking chronic, acute. That means when you give, what do you think? Okay. Okay. I'm not asking contraindication. I'm asking side effect, acute side effect. What will happen to people when you give warfarin right away? Some people are writing skin necrosis. Necrosis is all same. Good. when you put people on warfarin, there's a high chance they could develop a skin necrosis within the first few days. Now, I want to correct it. It's skin necrosis due to what causes the skin necrosis? Due to clotting. Is that? So you should be asking me, we are giving warfarin to prevent the clotting. How are we getting a clotting? Does that make sense, folks? So let's talk about this. I do not want anybody to write for the next 2 minutes until I finish, because it's very difficult to explain. Okay. Now, when I give warfarin, let's say I'm giving a patient warfarin, for example, today at 8 o'clock in the morning. Okay. Now I gave warfarin at 8 o'clock. That 8 o'clock will inhibit epoxide reductase, no more active vitamin K. Agree? Now from 8 o'clock, no more 2, 7, 9, 10 will be converted. Is everybody clear, folks? But I already have 2, 7, 9, 10 and CNS that was activated before 8 o'clock. Is that clear, folks? So whatever the medication that's activated before 8 o'clock. Now, in that, these 4 factors, which we call clotting factor, will survive in the blood for about 3 days. That's their half-life. That means 3 days. Okay, so that will be what, Sunday, for example. So I would have a clotting factor until Sunday in my blood. But whereas CNS will only be 4 hours. So that means it will go away from my body by 12 o'clock today. Is that clear, folks? So afternoon today, I have no C and S. These are the undercap, good people, isn't it, folks? Then what happened afternoon till Sunday, I only have clotting factors. Is that clear, folks? So that causes hypercoagulability in the first 3 days. So whenever you put a patient on warfarin, even though the long term is to inhibit the clotting, the first 3 days, they are actually at hypercoagulability period. After Sunday, all the factors are gone, then you don't need to worry. You're not going to make any clot. So everybody clear, folks? Okay, let's do one more time. Okay, so I'm giving warfarin at 8 o'clock today. When I give 8 o'clock, it will prevent activating the clotting factor from 8 o'clock onwards. But it will not do anything to the activated factors before 8 o'clock, which is already in the blood. Is that clear, folks? We already have activated factors in the blood. In that, the clotting factors has a half-life of 3 days, whereas the CNS half-life is short, only few hours. So then what will happen? By noon, CNS is gone. So there is nobody to neutralize, and you stab the bad clotting factors for 3 days until Sunday. So they could cause more clotting actually in the first 3 days. So every time you start a warfarin on a patient, the first 3 days, they are at high risk of developing a clot. So everybody clear, folks? Now go ahead and write it down on your way. Go ahead, Mike.
So what you're saying is it's not necessarily warfarin's fault that it's occurring. It's just the half-life issue that naturally occurs.
So the main reason, if they ask you, why do people get clot after giving warfarin? It's the short half-life of CNS.
Okay.
But
Because-
warfarin is an anti-coagulant, right?
What is it?
Warfarin is an anticoagulant.
It is anticoagulant after 3 days.
Okay.
The first 3 days is a problematic. Now, what did I say? It's at increased risk of making a clotting. I'm not telling every patient is getting a clot. Increased risk of clotting. Okay, so the question will ask you, why do people get skin necrosis with warfarin? The answer is short half-life of CNS. The CNS goes out first. Is that clear, folks? So there is no neutralizing product. CNS is a good people. Good people don't live longer. Okay. Harry, do you want to explain this back to us?
Sure. So you have inactive vitamin K that you get from your gut flora. It's activated by epoxide reductase. Are you talking about the warfarin specifically?
Yeah, warfarin.
Sorry. Okay. So you give warfarin, and in the first few days, it gives you a hypercoagulable state because you have factors 2, 7, 9, and 10, which are causing a hypercoagulable state, and they have a longer half-life. But you also have proteins C and S, which only have a half-life of about 4 to 5 hours. But when you give warfarin, everything is inhibited. So your CNS will kind of dissipate and you'll no longer have it, but you'll still have all the other factors. So you'll still get your blood clots.
For how many days?
For the first 2 to 3 days.
2 to 3 days. Very good. Is everybody getting this, folks? It's all about the short half-life of CNS. If CNS leaves the body, because after CNS leaves 4 hours, we are not bringing any more new CNS because your warfarin is inhibiting that. Is that clear, folks? That's the idea. Okay. Now, so what do you do? What if I suspect as soon as I give a warfarin, this patient might be making clot? How can I prevent that problem? That's why we start patient with warfarin and heparin together, and we stop the heparin after 3 days because the heparin can work acutely the first 3 days. Most of the time, we start warfarin and heparin together. After 3 days, we stop the heparin. Why do we stop? Because after 3 days, all the clotting factors are gone. We don't need to worry. That's why it should be saying somewhere that we bridge. So whenever you give heparin, it's bridging. Okay, so heparin is actually bridging between the warfarin and the 3 days, folks. Okay, that's the idea. So everybody clear, folks? So now let's connect the skin necrosis since we did. So this is a tiny blood vessel that supplies the skin. Okay, that supplies the skin. So I gave the patient warfarin. So what will happen when I give warfarin today? By noon, C and S is gone. Is that clear, folks? Then I have 2, 7, 9, 10 clotting factors are clotting. So they make a clot. They make a clot. That tiny clot goes to a blood vessel that's supplied to the skin. They blocked. Now, can the skin get oxygen? No. Ischemia, infarction, necrosis. Is that clear, folks? That's why. Now, does every patient with warfarin gets that? No. Always remember, people who take, they are at risk, which means some people can, some people cannot. Is that clear, folks? That's the idea, okay? That's where the skin necrosis.
What is the heparin doing?
Say it again?
The heparin, is it breaking it
I'm going to get
down?
to that next. That's our next topic. Give me a few minutes, we will get to that. So, okay, so that's warfarin here. Is everybody clear, folks? Okay. Now, next part here. What does antithrombin do? Look at the word antithrombin. We call it short, AT3. That's antithrombin 3. Antithrombin is all the same. Antithrombin is a protein produced by liver. That antithrombin inhibits all the factors. Look at that. 2, 7, 9, 10, 11, 12, everything, isn't it, folks? So I could tell the more antithrombin we have, the better to inhibit all the clotting factors right away. Is that clear, folks? So how do we bring in more antithrombin? Heparin does that. Heparin stimulates antithrombin. Heparin stimulates antithrombin. Okay, so if I give a patient heparin, I'm going to have more antithrombin, which means they will block all the factors instantly. Is that clear, folks? So now let's go back to this problem, see what we can do. Why do we add a heparin, right? Now, let's clean up this, okay? Now, let's say I give patient warfarin today at 8 o'clock. By noon, C and S is gone. You guys know that already. But 2, 7, 9, 10 is going to be staying in the blood for 3 days. Is that clear, folks? Now, that 3 days, people can get clot. So what am I going to do? I'm also going to give patient heparin right away. What that heparin will do, heparin will bring antithrombin. That antithrombin will come and inhibit all those things instantly. So you are not at risk for the 3 days either. Is that clear, folks? Because heparin brings antithrombin. Antithrombin inhibits all the active factors. That's why A is next to it. Is that clear, folks? Did I answer your question, Aliza? All right. So heparin.
Why don't you just give heparin instead of warfarin?
Say it again.
Or warfarin. So why don't you just give heparin instead of warfarin?
Oh, that's a very logical question. So the problem is you can't use heparin for long term. It has a lot of other problems. So heparin is always prescribed for short-term purpose, not for long-term purpose. So if I know that patient only need heparin like anti-clotting for 1 week, I don't need to start warfarin. I would just give heparin and be done with it. But if you see people who has atrial fibrillation is an example, they have to be on warfarin lifelong. You cannot give heparin lifelong, folks. That's why, okay?
Dr. Wright, I think I'm confused on a little something. Warfarin is supposed to prevent vitamin K, right? And vitamin K is supposed to
Activate the clotting factors.
right. But if warfarin is blocking it, shouldn't they already be inactive, the clotting factors?
That's a question. So if warfarin is blocking the clotting factors, it will only block new clotting factors to be active. But whatever they activated before, it's already in the blood.
Right. Okay. Thank you.
See, that's why I bring the time. If I give warfarin at 8 o'clock, I am blocking all the clotting factors from 8 o'clock onwards. But you have that you activated at 7:59, 7:58, all those clotting factors is in there.
So the heparin is also like this, it's blocked after the
No,
time you give them
what-
the medication, or
No, I said heparin goes and block all the active factors in the blood right away.
even the old one?
Old one, everything. Whatever they see in the blood, they will block.
Okay.
So that's why if I ask where does heparin works, it works in the blood. It goes directly to the blood and activate and bring antithrombin and inhibit all the clotting factors. Is that clear, folks? All right. So that's this too. See, you get a question in warfarin 200% on your exam. And this is how we do it. Okay. So now you know how, the only question you get, how does warfarin gives you skin necrosis? Simple. Now you know it's due to short half-life of protein CNS. Okay. That's the idea, folks. Okay. Now, if you talk about some other stuff here. Question, this is an old question, not anymore. They say this mother gave birth to a newborn at home. This newborn is at increased risk of which of the following? Hemorrhage. Why? When a baby is born, when a newborn is born, what is the first shot newborn gets? Whoever did pediatric rotation or OB-GYN. What's the first injection we give it to newborn?
Vitamin K,
Why do we give vitamin K?
because it helps to clot the blood
Why do you have to even give the baby?
because they don't have any gut flora.
That's what I'm looking for. Newborn don't have a gut flora. That means they cannot produce vitamin K. Okay. So as soon as the baby is born, the first shot that goes in their thigh, it's vitamin K. Now, if you give that birth at home, you are skipping the vitamin K shot. Is that clear, folks? Now, does that mean whoever was born in the house, they all bleed? No, they're at risk of bleeding. Is that clear, folks? Like the last generation, most of them were born in home and they are more healthier than people who were born in the hospital, right? So the idea is they're at risk of bleeding. That's all it is. Is that clear, folks? That's what they're trying to tell here. Okay. Now, okay, that's that. We're not going to talk about FFP and CC now. Okay, these are the basics. All right, so that's your basic part. Is everybody clear, folks? All right, so that concludes clotting factors. How does clotting factor works? How does platelet works? We talked about it. We know how to activate platelet adhesions. We know how platelet aggregation works. Now we are going to talk about the disorder of clotting factors and platelets. Then the platelet and clotting factor chapter is done. Is everybody clear, folks? All right. Now, one of the students asked about a heparin and warfarin measuring time. Okay, there's a PT and PTT. I'm going to get to it once we get there closer to it. Okay. Now, let's go find platelet disorders, folks, or clotting disorders. Go to this page, 433. All right, now we're going to talk about clotting factor disorders, okay? There's a main clotting disorders is your hemophilia. Hemophilia A, B, C. Look at the ABC, 3 clotting factor deficiencies. A is a factor 8 deficiency, B is factor 9, C is factor 11. Isn't it all 3 of them belongs to intrinsic pathway? Because of that, your intrinsic pathway, PTT is prolonged. Is that clear, folks? PTT is prolonged. That's the idea, folks, okay? Not the PTT is prolonged. Now, what are the symptoms of hemophilia? Hemorrhage, bleeding. They don't have a clotting factor, so they are bleeding. Hemarthrosis, bleeding into joints. That word is like a buzzword for hemophilia. Look at this guy's knee joint. That's a normal joint, and that's a bleeding. You could see the difference. How massive that knee joint is. That means they are bleeding that much in there, folks. Okay. Bleeding there, uneasy bruising and bleeding after trauma and stuff. So that's a symptom. Now, hemarthrosis is one of the most buzzword to pick up hemophilia. So when the patient comes with hemophilia, how do you treat them? You literally have to replace the factor they are missing. Is that clear, folks? If they have a hemophilia A, you have to give factor 8. If they have a hemophilia B, you have to give factor 9, plus desmopressin. Plus desmopressin. Desmopressin is the synthetic form of vasopressin, isn't it, folks? This is a second disease we are studying where desmopressin is an answer. So what's my question now? What's the first disease we studied? Desmopressin is an answer. Type it up. You know, we have to do recall as we study, right? What's the first disease we studied? I mean, there are many diseases we're going to learn. Overall, about 5 diseases you use desmopressin, but I'm asking the one we studied so far. The next one we studied so far, what is it? Central diabetes insipidus, isn't it, folks? Not nephrogenic, central, because they don't have it. That's why we give it, okay? So this is second disease. All right. So that's your hemophilia, very easy one, okay? You just have to memorize the factor for ABC and you go with it, folks, okay? Now, vitamin K deficiency, it's not common. Now, why? Because for us to have a vitamin K deficiency, you have to literally kill every single flora, which is not possible, folks, okay? So if they were to get vitamin K deficiency, they will have both factors are affected, so they both are prolonged, and bleeding time is normal, but PT and PTT is prolonged. That's all. I wouldn't even worry about vitamin K, folks, okay? So that's hemophilia. I think hemophilia is the only high yield when it comes to clotting disorder. Even hemophilia is going down because they asked so much in the past 5 years. So now the new topics. Now, if you go to this page, this entire page is a 7-star topic, folks, okay? You could easily get 2-3 questions just in this page. There's such a big diseases, your ITP, TTP, everything in there. Okay. So now if you see here, we're going to talk about platelet disorders now. So what we just did is clotting disorder. Does that make sense, folks? Now we are getting into platelet disorders. Before we learn platelet disorder, how can I measure a person that has a normal platelet or its functional platelet? We do 2 measurements. One is platelet count. Platelet count tells you how much platelet you have. Is that clear, folks? Now, how do I know if a platelet is working? You know, you could have a platelet, but then how do we know it's working? We measure BT, bleeding time. Bleeding time, it's a very unique just for platelet function. Okay, bleeding time is a unique for platelet function, folks. So that's why if you see in platelet disorder, we only take a look at platelet count and bleeding disorder time, folks. Okay, now because we are talking about platelet disorder, look at that. Every single disease has prolonged bleeding time because it's a bleeding time problem. Is that clear, folks? Anytime you have a platelet problem, you would automatically have this one, folks. Okay. Now we're going to talk about few diseases. Now, whatever I'm highlighting, we cannot miss it. But we still have to do the other two also. So I'm going to start with Burnett-Sollier syndrome. You're going to do it very good here because we know the physiology. Burnett-Sollier syndrome, I'm going to tell they have a deficiency of GP1B. Don't look at the book. Without GP1B, what will be the issue? Platelet? Is it platelet adhesion or is it platelet aggregation? I want to see who types. Everybody's typing adhesion. Please, it's both. Because when you don't do adhesion, you cannot do aggregation. Right? So it's both, folks. Okay. I would write next to it, it's an aggregation, adhesions, plus aggregation defect. Both will be affected. Is that clear, folks? So it's a both problem because when you don't have adhesions, you cannot do aggregation. Okay. Now that's a problem here. Defect of GP1B. Now you see this word abnormal ristocetin test. It is a very confusing to most of the students. I'm going to talk about ristocetin. So until that, ignore it. I could only talk about ristocetin if I am done with the von Willebrand factor. Until that, I cannot talk. Okay. So that's Burnett-Sollier syndrome. So if definition, if you are asked to explain, simple. GP1B is missing, no platelet adhesions, therefore no aggregation. Is everybody clear, folks? So your bleeding time increase. Platelet count could be normal or decrease. We don't care. Is everybody clear, folks? Okay. Now next disease, Glanzmann thrombasthenia. If I tell you it's a problem, you do not have 2B3A. So what's that problem? Adhesions or aggregation or both? Now everybody's going to type both. No, it's aggregation problem, folks. Okay, only aggregation. Okay, this is an aggregation problem because why? Here we are not causing aggregation. Very good. So there's a decrease platelet to platelet aggregation, defective platelet blood formation, folks. Okay, blood smear shows no platelet clumping. That means they are not binding. Simple. They are not showing that. So those are those two diseases. Is it a difficult disease, folks? No. One is GP1B missing. The other one is 2B3A is missing. That's Burnett and Glanzmann. Is everybody clear, folks? All right. So those are those two diseases. Now let's get to the big boy, ITP, right? We call this ITP. Idiopathic thrombocytopenic purpura. That's what the idea is, folks. Now let's understand the pathology first before we look at the lab value. Okay. Now here what's happening? There is an antibody against 2B3A receptors, folks. So if I were to draw a platelet, let's say in the blood vessel, this is our blood vessel, there's an antibody attached. Now when this goes in a circulation to spleen, what do you think spleen will do? What do we know about spleen? Spleen is a perfectionist organ in the body. Is that clear, folks? It's one of the OCD organ, what I call. What does that mean? Whenever blood goes to the spleen, spleen look for anatomical structure and physiological function. They look for both. Even though this platelet is fully functional, because they are carrying an antibody, spleen will start taking off all these platelets. They will remove those platelets from the circulation. They destroy that. Why do they destroy? Structurally, they don't look normal because they have an antibody attached. Is that clear, folks? Now, if you see here, destruction of spleen in destruction of platelet in spleen. Why spleen is destroying? Because these platelets carrying an antibody attached to it. Is everybody clear, folks? Would you get a splenomegaly? Yes, you will eventually. Okay. All right. Now you could see splenic macrophage, phagocytes, all those platelets, folks, okay? That is the basics. So if I ask you, what is the pathology of ITP? You're going to simply say platelet has an antibody against that receptor. So when they go to spleen destroy all those platelets. Because all the platelets are destroyed, your platelet count went down. Because your platelet went down, bleeding time increased. Is that clear, folks? That's your ITP, folks, okay? Now, that's the idea. Where do people go wrong here? They ask you, which of the following changes are noticed in the peripheral blood smear? Which of the following are seen in peripheral blood smear? Everybody jump and pick increased megakaryocytes, because that's what it says in the book, isn't it, folks? Is that a right answer or wrong answer? What did I ask? What do we see in the blood smear? Did I ask what do we see in the bone marrow biopsy? In blood smear, you see decreased platelets. What do you see in the bone marrow biopsy? Increased megakaryocytes. So when you read a question, pay attention. Are they asking the blood smear or are they asking the actual the bone marrow biopsy? Does that make sense, folks? So don't get confused. Blood smear is from the blood, bone marrow biopsy is from the bone, two different samples. Okay, so why do we have increased megakaryocytes? That's a negative feedback. Whenever the platelets are destroyed, your bone marrow tries to make new platelets. Is everybody clear, folks? All right. Treatment, we give steroid, some antibodies, antibody to antibody. So this antibody can go and bind to the antibodies that binding to the platelets, okay? And if nothing works, let's say we are giving medication and everything, nothing works, you have to remove the spleen. Why? Because these platelets are properly functional. It's because spleen is OCD, keep destroying it. So we have to remove the spleen. So everybody clear, folks? What do we need to do before we remove? Type it up. You need to do 3 things. What are those 3 things?
I'm sorry. So the problem is in the spleen, not in the cell, right?
In the spleen, yeah. Type the 3 things we need to do before we remove the spleen. I'm eagerly waiting for Maliha. Your face tells me. You have to give a vaccine against encapsulated organisms before we remove the spleen. And I want to know, don't type give vaccine. I want to know what are those 3 vaccines. Everybody's typing give vaccine, duh. What are the 3 vaccines? See the power of memory? Haemophilus influenza B, pneumococcal, meningococcal. Okay, meningococcal, pneumococcal, Haemophilus influenza B. They're very important, folks. All right, so that's the ITP. Is everybody clear with ITP?
Doctor, quick question. So the spleen destroys red blood cells, bacteria, and platelets. So like what?
One more time.
What exactly? Because I know the spleen, we talked about it before, talking about red blood cells, like they destroy red blood cells. I didn't know they did platelets and back.
Oh,
Like, I know.
Spleen can destroy any blood cells that comes inside.
Oh, okay. Thank you.
Anything it can destroy what goes inside. Okay, so that's that. Yes, that's.
So just to recap, the spleen is destroying the perfectly normal platelets.
Which has the antibody attached to it.
But the platelet, if it's normal, it already has the
Don't
antibody.
use the word normal, use the word functional.
If it's functional, it already has the antibody on it, protecting it, right? So this is just the spleen attacking those, and because of those antibodies.
Yeah.
Spleen. Okay, got it.
Okay, so that's your ITP. Is everybody clear? Any questions?
Sorry, I just got confused. What was that about? The antibody?
No,
I thought
no.
doesn't-
What she said was platelet has antibody attached to it. While they go in a circulation to spleen destroy the platelets. That's all.
But they normally shouldn't have the antibodies on it. It's
Normally
not.
shouldn't have antibody. Having an antibody to platelets itself is pathology.
Thank you
But
so much.
the platelets are still functional.
Got you. Thank you.
No problem. All right, so that's that, folks. After ITP, this is usually renal topic, but we started adding here, but let's talk about it, okay? It's called uremic platelet dysfunction, talking about simple. When you have a renal failure, if you have a kidney failure, kidney cannot excrete BUN. What does BUN stand for? Blood, urea, nitrogen. Is that clear, folks? So when people have renal failure, they have increased BUN. Whenever they have increased BUN, that increased urea, it inhibits platelet function. Increased urea inhibits platelet function. Look at this. In patients with renal failure, uremic toxins accumulate and interfere with platelet adhesions. Is that clear, folks? Now, that's the key. Now, it just increased the bleeding time. I'll tell you a quick story. We had a patient. They have some pre-existing condition, whatever. Finally, she had a renal failure and she was admitted. Okay. Now, when she was admitted for renal failure, we tried to do dialysis and stuff. Dialysis is a procedure that removes the urea from the body. Okay. She had a contraindication that we couldn't do dialysis. Okay. Now, she was intubated because when they have a renal failure, urea accumulates. Urea can become toxic and it even crosses blood-brain barrier. Anyway, so we have to intubate and do gas exchange. After a few days, no response. And our fear is anytime she can start bleeding from everywhere. Why? When you have a renal failure, urea accumulates, that urea inhibits all the platelet function. On about day 7, she started bleed from every hole in the body. Okay, because why? Your platelet is not functioning, it's thin. Her face started to break into 2 because of bleeding, folks. She died technically on the 8th or 9th day. But what I'm trying to tell, whenever you have a renal failure, most of the time people die. It's not just because of the renal failure, it's because of all the other complication that happens, okay? So the more urea you accumulate, the platelet doesn't work. You need platelet to function even under normal circumstances. Is everybody clear, folks? So that's the uremic platelet dysfunction. So you should know urea inhibit platelet adhesion. Technically, platelet adhesions mean platelet aggregation also. Is that clear, folks? All right.
Why would you need platelet adhesion in normal circumstances if you don't have any like endothelial damage?
No, see, remember, the platelets has to maintain the thickness of the blood. In order to maintain the thickness of the blood, they have to have some sort of coagulations that we call physiological coagulations. So the platelet endothelial injury is when you have a pathological conditions. So this is, we are talking about the normal platelet functions, okay? So that's the idea. In another word, the blood should maintain their consistency. When the blood become thin, they started to bleed through capillaries, okay? So that's the idea. Now, so that's uremic platelets, okay? Now, next one, TTP. That's a big one. TTP, thrombotic. What does thrombotic mean? Clot. And then thrombocytopenia. You have a clot and you have a low platelets, and that gives you the symptom of purpura. So you see them. Now let's understand what's that normal procedure. So let's go back to our picture here. Now let's say here, folks, I'm going to redo the drawing. It's too much is happening there. Now this is a blood vessel. You have 3 platelets, just to understand here, folks. Whenever there's an endothelial injury or whatever, physiology or pathology, platelet comes and attach. How do they attach? GP1B with von Willebrand factor. Is everybody clear, folks? And they do their function. Okay. Now, once they attach, that clotting is there for few days or whatever the time they needed. After their function is done, this von Willebrand factor need to be broken down. Okay. They need to be digested. They need to be cleared from the blood. Okay, now I'll give you a good example. Let's say I'm shaving, and when I shave, I cut myself, and then we bleed. After the bleeding, it will stop automatically in 5 minutes. How do we stop? We form a clot wherever you are bleeding. Is that clear, folks? When we form a clot, you will see a black colored dot. Is that clear, folks? Now, after, if you notice it 3-4 days, that black thing is gone, which means your blood clot, that von Willebrand factor is removed. Everything is went back to normal because it's all healed. Who removed the von Willebrand factor after its function? It's called metalloprotease. Metalloprotease. Okay. Now it's called ADAMTS13. That's another name for metalloprotease. Now, if I ask you what's the function of metalloprotease, simply to clear von Willebrand factor after its function. Is that clear, folks? They clear out all the von Willebrand factor after its function. It clears not into multimer. It actually digests. It's actually taken, removed from the blood circulation. Multimers mean actually making big. Okay. So it's opposite to that. So they clear it out. So ADAMTS13. ADAMTS13. Now, that's a normal function. That's a physiology. Is everybody clear, folks? Imagine if somebody has a deficiency of that. If you have a deficiency of ADAMTS13 or metalloprotease, can you clear all the von Willebrand? No. So the von Willebrand will be in the blood floating. All the von Willebrand is going to accumulate together to become a big piece. Is that clear, folks? When they have a von Willebrand, what happened? The minute platelet sees, they will attach it. Because on a normal people, you are supposed to release von Willebrand factor only when you have an endothelial cell damage. Is that clear, folks? Here, it's not actual damage. They just in the blood, not cleared. Look at this here, folks. Inhibition or deficiency of ADAMTS13, decreased degradation of von Willebrand factors that causes large von Willebrand multimers. Okay, so they become big pieces. So that will cause more platelet adhesion and aggregation. Because remember, folks, platelet doesn't know if this von Willebrand coming from new subendothelial collagen or it's a pre-existing. Whenever they see, they will attach to it. Is that clear, folks? Okay, so that's the idea. So because of that, they form the thrombus clot. Is everybody clear? When they form the clot, all the platelets is in one place. The rest of the area, you have decreased platelets. That's why thrombocytopenia. Yeah, that's why they are thrombocytopenia, folks. So that's the basic pathophysiology of TTP. It's not difficult. It's easy. Okay. Any questions so far? Okay. Now, if you see here, folks, some triad. So highlight what I'm highlighting. Patient should have thrombocytopenia. And next, highlight this guy. Microangiopathic hemolytic anemia. So let's say this is a blood vessel. So let's say this is a tiny blood vessel, there's a clot. And you guys know how we got that clot. Because von Willebrand is not being destroyed, all the platelets are attached to it. Okay. Now we have in the same blood vessel, we have a red blood cell. These dots are my red blood cell. Now imagine, folks, inside the blood vessel, there's a blood pressure, approximately 120/80. That means the blood goes such a fast pace. Is that clear, folks? Now what's going to happen? This red blood cell is going to go hit this big rock. that clot is considered rock. When the red blood cell hit the rock, what do you think is going to happen to red blood cell? They're going to break, hemolysis. That condition is called microangiopathic hemolytic anemia. Microangiopathy mean, angio mean blood vessel, micro means small blood vessel, hemolytic anemia. So your red blood cell is hitting this clot and breaking it down, folks, okay? When we break it down, we have something called schistocytes. Schistocytes, also known as helmet cells. It basically broken red blood cell pieces. Okay, write that down. Schistocyte is just a fancy word for broken red blood cell pieces, folks. Okay, that's all it is. So anytime you see the word schistocyte, you should know they should have had red blood cell broken into pieces. Is that clear, folks? So now, why do we have thrombocytopenia? Because all the platelets is causing clotting. They are in the clot, so rest of the place they have decreased. That's why thrombocytopenia. Okay. Now, these people also have kidney injury because all the hemoglobin released and all these things goes there, folks. So they have pentat symptom, 5 symptoms. They have thrombocytopenia, microangiopathic hemolytic anemia, renal failure, fever, neurological symptom. If I write 1, 2, 3, 4, 5, you have 5 things that represent TTP. Now, when I took step 1, you need to have all those 5 in order to diagnose TTP. But in the last 3-4 years, the Hematology Association of US, they declared as long as you have these 2, thrombocytopenia and microangiopathic hemolytic anemia, is more than enough to diagnose it. Is that clear, folks? So I repeat, as long as you have these 2, it's enough. These are minimum that's required. In another word, you need these 2 to diagnose TTP. Even if the patient has fever and neurological symptom, you need minimum thrombocytopenia and microangiopathic hemolytic anemia in order to diagnose. Is that clear, folks? All right. Now, this is a platelet problem. That's why your PT and PTT is normal. There's no need to involve the clotting factors here, folks, okay? Now, look at this. It happens typically female. That's fine. Now, that's thrombotic thrombocytopenic purpura. Is everybody clear, folks? Now, let's go to the site. So what is this hemolytic uremic syndrome? Is exactly similar disease of TTP, but it happens in children. It happens in children, plus it has an infection. That's all. Children, infection. That's it. Now, if you see, predominantly caused by Shiga-like toxin. It's produced by E. coli. We call this enterohemorrhagic E. coli. Remember that? Enterohemorrhagic E. coli? Enterohemorrhagic E. coli is the E. coli that comes when you eat uncooked hamburgers and all these things. And that's the only E. coli also gives you, where is it? Bloody diarrhea. Enterohemorrhagic E. coli is the only organism in E. coli species family that can give bloody diarrhea. So the question will tell you bloody diarrhea. And you need to remember this serotype, that specific E. coli, 015787, folks, okay? So that's it. Treatment, supportive care. There's nothing we could do. It's an infection. It's supportive, folks, okay? Everything get better on its own. So to differentiate TTP and hemolytic uremic syndrome, similar process, but it happens in children and with infection. Whereas TTP in adults, no infection. Is that clear, folks? All right. So that is your TTP and hemolytic uremic syndrome. Let's do some